All right, Jeanice, I'm excited for this discussion because I know this is a topic that has a lot of people feeling stressed. And so I thought you'd be a great person to have on as a guest because I think that you're just so, I love your lighthearted attitude and your humor about things while still being able to give evidence-based information. So thanks, Jeanice.
I'm honored to be here. Thank you for the opportunity.
So prolapse. I just feel whenever I say that term or whenever someone else says that term, you can just feel it's a bit charged, right? Because like I said, people have a lot of nerves around that term. And I think a lot of women picture that everything's just falling out the bottom. And, I'm never going to be able to get it back up. And how bad is this? And this means it's only going to get worse. And I've looked at Google and so many things come out of it. And I just thought if we go right back to the basics and start with, what is prolapse?
Yes, I know it's really a terrifying concept, right? And so many people think that, this is only something for older people. So if you've ever heard of the term a bladder lift or a bladder suspension or a fallen bladder, many times your grandmas or your aunties or your mothers might have said these terms around you and you didn't really even connect with what that was. And that was myself. So I was a physical therapist. I had my master's degree and I didn't know all of this about the body. So basically prolapse, I think it's important first to understand the canals that most female bodies have. Okay, so I have an image here, rather a model. So if you're listening to this, I want you to just visualize a female body that's cut in half from the front to the back. And so in the front, you have the pubic bone, and then you have the tailbone and the spine. And you have three organs that are your pelvic organs. And so you have the bladder in the front. So that's right behind a pubic bone. And that is kind of like a water balloon. So that's where your urine is stored. And then you have a canal that exits the body, and that's called the urethral canal. So that's where urine exits. Then you have the uterus and the vaginal canal. So that's where, a lot of people have sex. And then you also have the baby that grows inside the uterus. And then we have the rectum and the anal canal. And so this is for solid waste, liquid waste, and gas. And then also sometimes anal sex. So basically you have these three canals. And I like to think of it kind of like if you thought of of bowling lanes. Okay, so you have three bowling lanes and they're kind of straight. But what if, and let's call them bowling lane 1, 2, and 3. So what if bowling lane 3 started to kind of move over and swerve into bowling lane 2? And what if bowling lane 1 started to swerve over into bowling lane 2? So then that bowling lane 2 is no longer so straight, right? You have some kind of collapse. And that's what happens with pelvic organ prolapse. So that vaginal canal is starting to descend, either the front wall or the back wall. And those organs behind those canals, so the front wall has the bladder right behind it, and the back wall has the rectum right behind it. And so those walls start to collapse, and they can collapse a little bit or they can collapse a lot. And then also the uterus itself, which is at the top of that vaginal canal, can also start to drop. So there's many grades of pelvic organ prolapse, but that's I think one of the simplest ways to understand pelvic organ prolapse. And just because you have the term prolapse doesn't mean your uterus has fallen outside of your vagina. There's many stages and many different variations with prolapse.
I love that. I just love that visual. I'm definitely going to use that. I use those canals and I hold up toilet paper rolls and show people the same concept, but then show them how they're not. I think sometimes we picture that our organs in there are concrete, or they picture them rigid and that they always stay open. I think a lot of people picture that their vagina is always supposed to be open, but describing that, the walls are soft, and depending on what's going on beside, like you said, it can kind of encroach. And I wonder, just really quickly, because I think a lot of women are hearing their stages, and there's different ways to grade prolapse. I think one of the easiest ways to understand is the rating scale from 0 to 4. So Jeanice, will you just really briefly maybe just touch on what those grades might look like, because many women have questions around that.
Mm-hmm. So that's a great question. So I think that starting off, you need to again go back to the anatomy. So most everyone has heard of the hymen. All right, the hymen is basically like a very thin layer of skin that attaches close. It's in the vaginal canal, and it attaches close to the opening of the vaginal canal. All right. And hymens can vary so much. I mean, hymens could be a whole podcast topic
Totally.
on
Yes.
its own, but understanding where that hymen attaches is really important for staging the prolapse. Okay. So it's called the hymenal ring, and that's kind of a landmark that we use for a lot of prolapse staging. So just remembering in that middle bowling alley canal, you have a little line that's maybe a quarter to a third of the way up there, right? So you have a little line, and that's a demarcation line. And so when that bowling lane 3 is starting to drop into bowling lane 2, where is it in relation to that hymenal line? Does it go, is it above it? So a grade 0 is everybody's straight, everybody's staying in their lane. A grade 1 is just a very small drop. A grade 2 would be getting either close to that hymenal ring above it, or even close to it a little bit below it. And these grades apply to all 3 organs: the bladder, the uterus, and the rectum. So if you had like a grade 1 bladder prolapse, or we call it a cystocele, or an anterior vaginal wall laxity, then that would be where the front part of the vaginal wall is starting to collapse just a little bit. So let's use that, because that's the most common one, is the bladder prolapsing, or that anterior vaginal wall laxity. So you have, it's a grade 1 is further up in the canal. A grade 2 is coming to that line, or a little bit above or below that line. A grade 3 is actually coming, we say, like 2 centimeters or greater below that line. So this is actually, if you're watching this on the YouTube channel, if you look, like if you took a mirror and you put it in between your legs and you're looking at the vaginal opening, a grade 3, you'd be able to see kind of like a pink bulge. A lot of times people think, oh, I'm going to see yellow structure because it's my bladder, but it's actually the vaginal wall that you're seeing, right? Going back to those bowling lanes, that lane is taking everything with it, right? So similar concept there. And then a grade 4 is complete eversion outside of the vaginal wall. And this might actually feel like you're sitting on a golf ball, like you'll see a pinkish bulge. And generally it's more pronounced when you're standing, especially towards the end of the day, if you've been very active. Gravity has a way of making gravity isn't necessarily the friend of prolapse.
Exactly.
And so if you've been very active, then so grade 4 is complete eversion outside.
And so would you say, because obviously we know there's not necessarily a correlation between what people feel and what the grade of prolapse is. Like quite often, someone will say, oh my gosh, I have the worst symptoms ever. It's really, really bothering me. But then when you assess them, oh, I actually, what I'm feeling doesn't match up with what they're saying, and vice versa. Sometimes people can have a pretty significant prolapse. I've seen this in the clinic. I think, oh, wow, she's not mentioned anything at all, and so I think just understanding that your symptoms don't always match with the grade of prolapse. And I think maybe let's move on to what people might experience. Like what are women talking about, or what are they describing when they have some prolapse?
Before we jump into that, I'd like to just tag on something to what you just said. So let's say that and I definitely do agree that symptoms don't always correlate with staging, but I would also say, and this was me for a long time, like if you're grading the prolapse and they're lying down, and especially if it's more towards the beginning of the day, you may not be seeing the prolapse at its worst. And so I would encourage you, if you're listening and you're a provider, think about that and think about positioning. So So we've, in our clinics, had people who were either a 0 or a 1 lying down, but then we get them and we test them in standing, or we test them in squatting, and then that prolapse descends more. And so I would encourage you, especially if you're a provider, check them in standing, check them in squatting. If you're a patient and your provider isn't necessarily seeing the significant degree of prolapse that you're feeling, ask to be checked in standing, ask to be checked in squatting, ask to be checked towards the end of the day, ask to be checked, because symptoms can also vary, like with your monthly cycle. So if you know that your symptoms are worse at one time of the month or the other, I would make your grading or your staging appointment to kind of correlate when the worst of your symptoms are, so that you can get the best possible staging. Okay, so
that's good. No, that's good that you went there, because I wanted to go there later and talk about, what we are assessing as therapists, and talk about a little bit about that, because I think, like you just said, you get a lot of women come in saying like, oh shoot, I don't feel how I normally feel right now. And you're assessing me at a time when it doesn't normally bother me, because I think you're right. It's important to note that it will change all the time. And it is probably 99% of the time, these women are assessed lying down when they don't have symptoms. Exactly.
Yes.
And I think it's important to, like you said, be able to talk about, I always start with them lying down, just because I want to get a sense of what it feels like. But it can be a marked difference as soon as they stand up, right?
Yeah. And tagging on one more idea to that too, is that somebody with a severe prolapse may not even understand the symptoms that they're having are bad or negative, like, okay, or so like some of these surveys out there about prolapse, do people even understand what the symptoms are to be able to identify that it's bothering them? And so that segues into your question, like, what are symptoms of prolapse? Yes. So the two key cardinal symptoms are a vaginal bulge and pelvic heaviness, or that dragging sensation. So those are two of the key signs. That doesn't mean that those are all of the signs. And so we can dive into some of the other signs and symptoms too. But if you have a vaginal bulge, or you have that pelvic heaviness or pressure, grab that mirror, look at it. And, I would actually try, okay, so you have a mirror and you're standing and you're looking at it. Try lying down and see what happens to that vaginal bulge. And then try lying down and putting your hips up on a couple pillows, so your hips are above your heart, and see what happens to that vaginal bulge. So you can't diagnose yourself with prolapse, like that needs to be done with a healthcare provider, but you can see if you have a vaginal bulge and if it changes based on gravity.
Absolutely. And I think that it's important. I do that a lot too, asking people to, assess themselves, or just, familiarize yourself. However, I think it's interesting. Most women do not look at their anatomy before they have a baby. And I'll never forget this one lady coming in. She, Melissa, I need to come in ASAP. I have prolapse. I'm all consumed with it. And I had to think for a minute, and I said, wait a minute, you had a C-section, right? And she said, yes. And I said, did you have to push for a while? No. And so it just made me think that the mechanism just wasn't there. Anyways, when she came in, she's like, oh my gosh, feel it. It's caving in. I said, have you ever put your finger in your vagina and explored before you had a baby? No. And so again, I think sometimes as soon as you hear that walls are caving in, women, it's hard not to go straight to, oh my gosh, worst case scenario. But again, I think that's the benefit of understanding your anatomy before you have a baby too, right? Yes. And that maybe it's not as far off as what it was before. Yes. Because those bowling lanes have give, right? And especially depending on your positioning, when you sit and all those organs are kind of pushed together, you're going to get encroachment, or as you bend forward to assess yourself. And so I think, I think it's great that women explore themselves, but then sometimes they go straight to panic mode, don't they?
Right. And yes. It may just be the urethra that they're seeing, right? That
exactly.
Meatus tissue that they hadn't ever seen before.
Exactly. So the power of understanding, right? Okay. So Jeanice, I kind of cut you off, or we got on a tangent about some of the other symptoms. What might be some other things that women notice?
Yes. So sometimes you might feel like, it's difficult to empty your bladder. So you sit down and man, it takes a while for it to start, or you have to shift on the toilet to empty. So that's a sign like that urethra, that urethral canal, you're having to shift to kind of readjust it so that the urine is flowing out, like that water balloon that's kinked. We want to unkink that so that the urine is flowing out. And then something similar can happen with the bowels. Mm-hmm. So if you're having a difficult time emptying your bowels, or if you feel like they're not emptying all the way, if you take your finger and either put it on the outside, so let's go over a quick anatomy here again. You have 3 holes. You have the urethra towards the front, that's where urine exits. You have the vaginal opening, and then the anus. That's that area of skin in between the vaginal canal and the anus. It's called the perineal body. And so that's an area frequently, like if you have a perineal tear, if you have an episiotomy, that's that area that's affected. But if you push up on that perineal body, or if you even put a finger inside the vagina and kind of push it back towards your rectum, like if that helps you poop, then likely you have some type of prolapse. It's not a guarantee. You need to go see a provider, but that's a sign. Sometimes people have pain with prolapse, but that's not a cardinal sign. So pain can, I've even had people with tailbone pain, especially like with a rectocele, that's where that posterior wall. You can have urinary leakage. You can have incomplete emptying of the bladder. Sex can be uncomfortable for people sometimes. Occasionally you may feel like, let's say you have a penis that's being inserted into the vagina, you may feel like something's blocking it or hitting it, but generally that's a fear that isn't most times reality. So if you have a prolapse and you've been diagnosed with it, and then you're thinking, every time something's being inserted, it's going to hit this bulge. But most of the time when you're sexually active, you're going to be lying down. Not always, but a lot of times. And so again, that vaginal canal is very stretchy. And when you're lying down, gravity kind of has a way of helping to reposition things. So most of the time it's not an issue, but again, it can be an issue like where it feels like something's being hit.
And
did
also,
I miss anything?
Well, I was thinking, my first thought too was like just the thought of like something sitting in there, or like a tampon sitting in there, or not being able to keep the tampon or the menstrual cup in place, I think is another one that a lot of women will describe. And
that's a really good one.
I wonder, can we move to then, because the majority of people listening to this will be either pregnant or postpartum. And can we talk about how common it is to have prolapse after birth? Because I think people will put themselves into the category of, I shouldn't have it. And, oh my gosh, I've been told I have a grade 1 prolapse. And so I think, I spent a lot of time just diffusing and educating and just in helping women understand that's normal. So can you talk a little bit about that?
Listen to this. 30 to 76% of people that have had babies will have some type of prolapse. So that's
exactly.
That's almost 3/4 of people. So it's far more common, and I think the stigma, like, oh, my organs are falling out of my body. No, there's different stages like we just talked about, and there's different symptoms, but it's a very, very common condition. But most people either don't have symptoms, like 10 to 15% have symptoms, or the symptoms that they're having, they're not identifying it with prolapse. So from that study that showed 10 to 15% have symptoms, I still wonder like if people have symptoms and they didn't connect it with their prolapse.
Exactly.
But again, that's what the study says. So very common.
And then let's go back to that lady I mentioned. And I was saying that I kind of thought, oh, you probably don't have prolapse, because it would be way more common in women that have had a vaginal birth, and pretty well exclusively. I mean, there's other reasons you can have prolapse, generally from things like a chronic cough or heavy lifting a lot. But generally with the population we're talking about, if it's related to birth, it's going to be related to a vaginal birth. And obviously you can picture that as a baby comes out that middle bowling alley lane or that middle lane, that the walls have to stretch. When you picture how big your vagina is and how big a baby is, you have to have stretch, right? Yeah. And I think it helps women to understand that that's normal to have that let's say, stretch or laxity in the walls, and maybe helps them understand why rest is so important postpartum.
Yes, yes,
Right.
yes.
And because there's amount of time that, no matter the significance of your prolapse, there's a certain amount of time that you need for those walls of the vagina to be able to have, time to heal and to feel like they have more to them, right? They're more robust again. And so can you talk a little bit more about some of the other factors that would influence prolapse in the postpartum period? So vaginal birth itself.
Yes. So there's some things that can happen in a vaginal birth that actually are a risk factor for developing prolapse. So the use of forceps or a vacuum increases your risk of prolapse. Overstretching of the tissue. So if you, like we were just talking about, it's the vagina is meant to stretch, the pelvic floor muscles are meant to stretch, but sometimes they don't always go back. Think about your bicep where it attaches at your elbow joint and up to your shoulder. The pelvic floor muscles stretch up to 4 times their resting length. If you took your bicep and you stretched it up to 4 times that resting length, it would rupture. It wouldn't have the elasticity in it. And so the pelvic floor are very elastic, but they can get overstretched. Another risk factor is tearing. So especially like a grade 3 or a grade 4 tear from a vaginal delivery. And so that's going all the way to the anus. And so that increases your risk. And then also deep tearing of the pelvic floor muscles. So the grade 3 or 4 tearing, that involves the pelvic floor muscles. And then the deep tearing, so it's called a levator ani avulsion, that also increases your risk of tearing. And I think that could be a whole other topic that I'd love to do another episode on. But those are some risk factors in a vaginal delivery that if you had those risk factors, also I believe it's like greater than 2 or 3 hours pushing in stage 2. I don't have that stat right up, but prolonged pushing in stage 2 also does increase your risk.
Well, and you can imagine too, I actually don't have this information in front of me, and I wonder if you know, but a lot of women will ask, like, well, is it because my baby's head was big, or is it because my baby came fast? And all of that is going to contribute. I don't know the numbers on that, but you can imagine that there's so many factors. It's hard to say. I mean, genetics play a role. So many things. It's hard to say. And I think it's important for women to know you didn't do anything wrong. I mean, having a baby is taxing on our body, and it's beautiful, but there are things that change. Just like, I think, as we get older, we're going to get gray hair, and, some people are going to have more gray hair than others. And I think that, part of what you can expect from a vaginal birth is some degree of prolapse, right?
I mean, unfortunately, yes. And so this is an offshoot, but like there are predictor tools out there for the oasis tears. At this point, I don't know of a predictor tool for prolapse specifically, but there are factors that you can look at in advance in terms of levator ani avulsions. And so if you're at a high risk, either for the grade 3 or 4 tear or for a levator ani avulsion, either based on your body makeup, your history, the baby, and so forth, I think that's a very frank conversation that you need to have with your birth provider. Like, is a vaginal delivery something that I can, hopefully successfully achieve? But if you're at a high risk, you're in one of those high risk categories for a grade 3 or grade 4 or a levator ani avulsion, you may want to consider a C-section. So I don't think that there's any shame in that. And I think that there's been a huge anti-C-section movement. And I'm not anti-C-section. I'm not anti-vaginal delivery. I think you need to look at each person and understand where they are, how old they are, all of their body makeup, and look at all those factors and have that discussion in advance. There's some really exciting guidelines just released by the Australian Committee on quality and healthcare safety, that go over some of the risk factors and how to manage grade 3 and 4 tears. And so I would love to, and a big thing is communication during pregnancy, during labor. And if you did have a grade 3 or 4 tear, communication afterwards. And they actually advocate getting pelvic PT in the hospital before you go home. So I love that communication. So again, I know we went off track, from prolapse, but all of these things kind of lead, they're risk factors. So the grade 3 and 4 tears, the levator anti-avulsions, these are all things that can potentially, make you at a higher risk for developing prolapse.
I actually am glad you went in that direction, because I'm starting to see, I'm sure you're the same, more and more women come in during pregnancy looking to be proactive, but some of them have come in with, I would consider traumatic vaginal births. There's two off the top of my head. One is significant prolapse after that she felt she really had a hard time emotionally dealing with after. She lifted heavy weights and felt like she had very little support from her care providers and just, oh, well, that's what it is. She was terrified going into her second pregnancy. Another one, very significant grade 3 or 4 tearing. I can't remember the details, but I do remember her being presented the option with C-section or vaginal birth. And both of them, they spent the time educating themselves, learning about their body, learning everything they can do. But in the end, they both chose to have a C-section. And I think they're both very happy with their choice. And I think that that's all you can do is educate, learn, and then it's up to you. And whatever your choice you make, you should be proud of, right?
Yeah. And don't shame people. Don't shame people for having an elective C-section if that's what they choose.
Yeah, exactly. Great. I know, I'm really glad you went there. And I actually wanted to really quickly bring up, you talked about, I think it was 33 to 70% of women have some degree of prolapse. Someone else brought to attention another study the other day, I think was done in 2003. And they looked at, there was a doctor looking, I think almost 500 women at their annual visit between ages 18 and 82. So this was a pretty wide range of women, but he was checking to see, what grade of prolapse they had. 6.4% had grade 0. That's it. Grade 1, 43%. Grade 2, 47.7%. And then grade 3 was 2.6. There was nobody with a grade 4. So I think sometimes and I always talk to women too, when they come in and I explain, I have a grade 2 cystocele and rectocele, just so that they understand, like, I quote unquote know all of this and I still have prolapse, right? But I always say, I know it because if I assess myself, I can feel it. And in the courses that we do as pelvic health physios, we have to assess each other. And almost everyone that assesses will say, oh, you have a rectocele. They'll bring it up right away. So I know that it's there, but I don't feel it on a day-to-day basis. And just to give a sense that you can have some prolapse and it doesn't necessarily mean that your life is over, right?
I'm going to add on to that. I have a grade 3 cystocele and a grade 2 rectocele, and I do not feel it the majority of the time. And if I do feel it, I know exactly what to do so I don't feel it anymore. So I have strategies and I am doing everything that I want to do. And so it's absolutely possible to live a wonderful life with prolapse.
So then let's segue into, let's say that women are listening and they think, oh, either I'm pregnant and I want to know more about this, or I'm postpartum and I'm feeling some of the things that she's mentioned, or maybe I just want to be proactive because this is the only vagina I'm going to have for the rest of my life. We obviously, as pelvic health physical therapists, see many women. Can we just really quickly touch on what women could expect when they come to see us? So we've mentioned that we would do an exam, but what are some things that we would do to help them, like you said, live with it, manage it not be on the radar every day?
Yep. So I think another important part, even before that exam, is doing an outcome measure. And so these are basically standardized questions. Different physical therapists will choose different measures. I love the Australian Pelvic Floor Questionnaire. And if you Google it, you'll find it. And basically, I think scoring yourself and going through and getting your baseline scoring and then periodically scoring is a really helpful tool to objectively measure progress. Because sometimes when you're in it, you're not you may actually be getting better, and it's hard to know.
Absolutely.
It's kind of like watching a child grow, right? Like you make marks on the wall to measure progress. So measuring progress, going into that pelvic PT appointment, understanding that, be prepared for an intravaginal assessment, and also asking, being proactive about having one in standing, checking your pelvic floor. They're going to check your tone, your strength, your sensation, your reflexes, all of that. So you've gotten the pelvic floor assessment, and let's say that your pelvic floor muscles don't have great coordination or power or endurance. One of the key things with pelvic floor physical therapy is pelvic floor muscle training. And so that's basically training the pelvic floor muscles to do the right thing at the right time. There's a great study that showing the morphological changes that happen to the pelvic organs and the pelvic floor as a result of pelvic floor muscle training. So this was a 6-month regimen. They did pelvic floor muscle training almost every day. So it's a huge commitment. But at the end of that 6 months training, guess what they found? That hammock of pelvic floor muscles was thicker. So like our bicep, when we're training it, we want it to get thicker. So it was thicker, it had better tone, it wasn't as stretched out. So it was a better position, it was elevated. And then the rectum and the bladder, both those canals, those structures were elevated as well. So those are the morphological changes that actually happen. And then in terms of symptoms, it was either 74 or 76% of the people participating in the study had reduction in symptoms, major reduction in symptoms. So even if you still have the actual physical prolapse, the morphological changes are there, and then the symptom reduction is there. In that study, 19% actually reversed. And so I know a lot of people are kind of like, oh, reversal is the only cure, right? But I think we need to reevaluate how we're looking at that. So if our eyes are getting blurry, we put on glasses. Is that failure? Have our eyes failed us? If we need some extra support on our belly, maybe we have a diastasis, maybe, for whatever reason, we want to support that tissue better, or even our breasts. Okay. So giving some extra support, is that a failure? So no. And so I want people to listening to understand that reversal is not the only form of success, and you may want to reevaluate what success looks like for you.
And by reversal, you mean that there's no more, it's not detected on exam anymore.
Or it's
improved
up a stage. Yeah.
Right. Okay.
So reversal meaning it went from a 3 to a 2,
yeah.
or a 3 to a 1. I would tell you that although it's not an expectation, because looking at this study, right, like the majority of people aren't actually in the studies reversing their prolapse. Do some of them reverse it, meaning they go up a stage? Yes, but it's a minority of people. And so as I'm working with people, I'm educating them, and I'm trying to set that expectation. But I will tell you, like I have a small group coaching program where I accept 5 people every 3 months. So it really is a very intimate group. And I had a person last week. So we're 3 months into our program, and she had gone to be checked prior to the program being started, and then she got rechecked last week by her provider. And they did something called the POP-Q staging, which is with a stick, and you take a lot of intense measurements. And she had reversed her rectocele from, it was a grade 3, maybe a 2 at sometimes, but a 3 to a 1 in 3 months. I mean, and so that's so incredible and so exciting. So I don't want to say that reversal never happens, but set your expectations. Let's make those morphological changes. Let's do what you can. Kind of thinking about the AA serenity prayer. God grant me the peace. I can't even remember it right now, Melissa. The wisdom, the courage, man. This is so sad. The courage to accept the things I cannot change, the wisdom to change the serenity to accept the things I cannot change, the wisdom to change the things I can't. No, the courage to change the things I can, and the wisdom to
Know the
the
difference.
I'm so sorry. I just muddled that up. Google the Serenity Prayer, the AA Serenity Prayer,
Yeah.
because it really applies to pelvic health too.
Yeah.
There's some things you can change. There's some things you
Yeah.
can't. Let's keep moving and do what you can.
Yeah. Absolutely. And I think just while we're on the note of the pelvic floor, because that's something that we'll look at. And I think you did a really good job of helping people understand that it's a coordination thing. It's not simply Kegels. And I think that a lot of women picture, or they have this image again, with this downward movement of the organs, that if I just strengthen my pelvic floor and hold it tight, nothing will come out the bottom. But no muscle does well when it's just held tight all the time. And so I think that's and you didn't, nothing about what you said made me think that, but I do believe that there's this misunderstanding that if I just do more Kegels, it'll hold it up. But many women will notice that their symptoms don't change, or maybe even become worse, because they have a group of muscles that's not overly supportive from the bottom. So yes, that's one thing we address, is support from the bottom and coordination from the bottom, so that those organs feel supported. Will you talk a little bit about, just touch on some of the things that we'll look at for pressure management, maybe in their exercise, in their job, in their lifting their baby. So touch on that.
Mm-hmm. So a key thing is constipation. So avoiding constipation. When you're on that toilet, already your pelvic floor, that hammock is kind of sagging there. It's in a really vulnerable, unsupported position. And then if you add on straining on top of that, that's really bad for the pelvic floor. Some strategies that we really want to implement when you're lifting. So coordinating breathing and coordinating engagement of your pelvic floor and your deep core muscles. So the pelvic floor is part of the core. And so coordinating that, I like to coordinate it with exhale. So let's say, generally we'll start off with something small, like lifting, let's say even lifting a cup. Right? So take a deep breath in, and you're exhaling, and you're lifting, and you're engaging that pelvic floor. You're engaging those deep abdominal muscles while you're doing that activity. And then adding on progressive activities and simulating your daily lives and simulating the activities or positions that are causing you symptoms can be really helpful. And then, I also am a huge, huge proponent of additional support from below if needed. So that there's something called pessary. So pessary is something that you insert into the vaginal canal to help it stay more in its lane, right? To help it stay supported. And then there's also pessary-like devices. So some people can use a tampon inserted into their vaginal canal. And we didn't preface all of this, but none of this is medical advice, and it doesn't replace evaluation by a healthcare provider. So this is information to increase and raise your awareness. So there's a variety of devices out there, and there's more and more. I feel like every day I'm finding more.
Yes.
And then there's also some external support to kind of help lift from below if you need that extra lift. And so those are helpful. Have I missed anything that you're thinking?
No, I think that you've definitely touched on it all. And I think that a lot of women are terrified of exercise because, am I going to make it worse? Are things going to fall out? And I think that that's something that is beneficial to have assessed by a physio or care provider, because what we want to see is, show me what you're doing, tell me what exercises are your goals. Because many women are surprised that when they do certain exercises, when we point out, look at how you're driving a lot of pressure down. Do you see how when you hold your breath or when you engage your muscles in that way, do you notice what it's doing to that pressure sensation down in your vagina or in your rectum? But I think just learning to not necessarily feel like you have to cut out all exercise, but how to modify and how to coordinate those muscles so that you do feel supported from the bottom. And Noah, you touched on all that.
Can I add one thing in there?
Please. Yeah.
Consider the type of exercise you're doing too. So high impact is going to be a lot more pressure on that pelvic floor. That doesn't mean you can never do high impact again. But if you have prolapse and you're having symptoms and you're running, let's back up. So let's do some of that core rehab. Let's get you to where you want to be. But symptoms are a sign that pressure management isn't happening in the optimal fashion. And so let's back up, let's strengthen, let's rehab, let's use tools and other interventions if we need to help you achieve your goals. But again, high impact, definitely puts more pressure on that pelvic floor. And I like to think of it kind of like a trampoline.
Yes.
So you want, as something lands, so those organs are going to land on that trampoline, right? You want it to give, but you want it to have enough stiffness that it rebounds back up. Give, stiffness, rebounds back up. And so the more pressure you're putting on it, the more it has to support. And so just consider modifying your exercises at the beginning. And we have a lot of different tools and ways that we can.
Absolutely. You know, we've touched on different things that would contribute to prolapse postpartum. For example, you know, vaginal birth, you know, time is important. One thing we haven't really talked about is hormone changes. And can you touch on that? What's different about the postpartum woman, especially the woman that's breastfeeding?
Yeah. So basically you have a huge peak in your third trimester of estrogen. And so estrogen is a wonderful hormone that helps with lubrication. It helps with tissue fluffiness and blood flow and helps to make those muscles kind of juicy and healthy. And in the postpartum period, it drops significantly. And then with breastfeeding, again, the prolactin is basically telling estrogen not to come back. So you have very, very low levels of estrogen. And so that can affect your tissue quality, that can affect your symptoms, that can affect your lubrication. And so sometimes people find that stopping breastfeeding helps, but you know, I think the research really is mixed out there. And at this point, the research doesn't support that hormones, whether it's local or systemic, actually makes a change in the prolapse. In some of the polls that I do on Instagram, I would say it's about 40 to 60%, you know, and it depends on the week. So I might even just say 50-50, where people feel like breastfeeding made a difference, breastfeeding didn't make a difference. So, you know, understanding that estrogen plays a role in your tissue health. And in some people, it makes a difference in their symptoms. Some people it doesn't.
Good to know. I think then, just in summary, I think it would be an interesting way to summarize if we talk through, again, someone's listening to this and they think, okay, I'm interested now in going down this path to help, you know, assess. I want to have an assessment and I want to know what to do. So in Canada, women do not need to go see their doctor to come see a physiotherapist. And I believe in the US, it's the same.
So most states are now direct access, where you
Okay.
can go straight to a physical therapist without seeing a physician first. However, there are some insurance requirements that still need to be met. So I'd really double check with your insurance provider if you're not cash pay. If you're cash pay and you're going to pay, you know, out of pocket, then as long as your state has direct access, which most do, then you can go straight to a pelvic PT.
And I know some people listening will want to know, when should I come see you? When do you tell women that you want to see them, Jeanice, whether it be through online appointment or in-person appointment?
Mm-hmm. So in terms of the
Postpartum specific.
yeah.
Yes.
So generally, like by that 6-week mark, I'd like to start, like once you are cleared to resume sexual activity, I'd really like to see you in clinic. That doesn't mean that I couldn't see you before, especially if you're having a lot of pain or symptoms, because 6 weeks could be a really long time. But frequently, you know, that's a time for rest and recovery, and we're not really pushing a lot of exercise right then. We're trying to just let the body recover. So generally, I'm going to say 6 weeks. And leakage, pain, that vaginal bulge, heaviness, tailbone pain, all of those are signs and symptoms that we want to see you. And when I say leaks, a lot of times people just think it's urine. It could be bowel, it could be liquid waste, solid waste, or even gas. So gas leaking is a sign that, hey, and that doesn't mean that you have a lot of gas, but if you're not able to control your gas and you're passing gas at times that is embarrassing for you and you're not able to control it, that's a sign that there's probably something going on with your pelvic floor muscles.
Absolutely. I actually like to use, I've been seeing my clients often the first time through online appointment, and I've been encouraging them to reach out as soon as they're ready. And I've been contacted as early as 1 week, and never because I say we have got to get you exercising, you need to get on this regime, but more I do feel like it diffuses some of the fear. And I see everything from women saying, I feel really good and I'm nervous, I'm going to do too much. Can you talk me through expectations for, what I could be working on to be proactive? Or I have some that are, oh my gosh, I'm feeling this heaviness and pressure and I haven't been given any guidance. What should I do? And I'm actually a big fan, and this is why I created my online program. It kind of is meant to sit in that first 6 weeks. Obviously, people can take longer, but it's not, like you said, rest is the most important thing. But I do acknowledge that our body's been through something big, whether it be vaginal or C-section birth, and just helping women understand how something as simple as their breathing, or when they lift up their baby, how to think about that gentle coordination, or just getting the flow, like you showed on your bicep, like just getting the flow of those muscles moving again, I find helps immensely, not only with their mental health, but just, again, prolapse can be expected after birth. And so just being proactive so that when you get back to your exercise, you've built that foundation. And so I think that women are starting to reach out sooner and sooner. And I think anyone listening, I want you to know, as soon as you're ready is the right time, and any time that you feel like you have concerns is the right time to reach out.
I love that. I love that statement. And I would also add on to that, just because you can do things doesn't mean you should be doing them. So I remember after my first baby, oh my word. So lifting that car seat, I had a big diaper bag, I had a big purse, and I'm hiking up and down 3 flights of stairs to my apartment, and I'm cringing at, because I had a severe perineal tear, and I'm cringing at, the lack of support that I had, and I just didn't know. So just because you're feeling great. So I love that proactive approach. Hey, when you're ready, connect. And I think it's unrealistic to assume that people are just recovering and resting.
Yeah.
They're doing things. And so let's help them do it the right way and engage the core and gently help those muscles along and reconnect. So
absolutely. Because I think
definitely can check out your program. I think that's incredible.
yeah, and I think that that's kind of at the end, and a lot of women, they're coming in with the motivation that is, I've heard my mom and grandmother going through these things. So I think in the end, just taking that proactive approach for the long-term health. To close off, Jeanice, can you tell me, you've touched on your small group coaching sessions, and I think those would be valuable, but do you also have, I know you have another offering that you've recently put out that people can work through on their own time and at their own pace. Can you talk about that a bit?
Yes, so basically it's called Power Over Prolapse, and it's a self-paced course. It's a video course, and then it also has different attachments and handouts and worksheets and so forth. And it's about 5 hours, depending on how fast you go through it. So it goes over a lot of the anatomy and understanding how the body works and the pressure system and all the key players here with prolapse. We go over interventions, and so we go over exercises and connecting with your pelvic floor. I also have several add-on modules that we've had special guests come on. So we've had one on constipation, and it's just a really exciting group, and I think it's an exciting way to learn. So basically, you can stop and start it at any time. You can also drop comments. So if you have questions in there, I regularly check that and respond. And so that's another nice opportunity to learn about your body, to learn about prolapse, to learn about research. Like, I think we have over 50 different research articles that we quote in there, because there's a lot of misinformation and fear out there. So understanding your anatomy, I think, is key. And then understanding what the research says as well, is the key to having power over prolapse and to living the life that you want to live without pain, pressure, and leaks.
Exactly. I think a lot of people have a hesitation about online programs because I think, how could this person actually know what my problem is? But I think you and I would both say that I think it's important to educate yourself and to digest that information, because then when you are ready, you get your feet wet, you go in to see a physical therapist, you're ready for that. Because I think otherwise we spend a lot of time having to consume your appointment with just talking and educating. And I find if you can learn all of that and practice it and try to put it in your day, you'll come in, you'll say, I am having a problem with this, whereas you come in and you say, I'm here to learn. And a lot of your appointment will be consumed with talking. Right. And so I think the more you can educate yourself before you go in to see someone one-on-one will only serve you well. So in the end, Jeanice, anything else that we haven't discussed you think is
No, I
important?
think it's great. I will say that I'm going to give anybody listening here a 50% off coupon for the Power Over Prolapse online course. And so, Melissa, you can post that. And then I have periodic challenges as well that are free challenges on prolapse. So check out my Instagram, because that's probably the best way to stay up with the different things that are going on. But I also have a website, mypfm.com, and my Instagram channel is My Pelvic Floor Muscle.
Yeah. Her Instagram account is amazing, and I'll link all of that in the bottom.
Thank you.
I thank you so much for your wisdom and your time and just your attitude.
Oh, Melissa, it's been amazing. Thank you for the opportunity. And I hope that this conversation has taken some of the fear and the stigma out of prolapse, and understanding that I'm almost 49 and I've had prolapse since my first baby. So he's going to be 22 in December. And so you can have a wonderful, active, vibrant life with prolapse, and that's okay.